Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagapet. So we are learning about the topic on fluid and electrolyte balance. So in the previous class, we learned about the common anions, cations, and their values and their functions we have studied. Now let us study the disturbances in fluid and electrolyte balance. So if there is any excess or deficit, how it manifests, let us study. Clinical manifestations: changes in the volume of electrolyte-free water. So if only plain water without any electrolytes is either gained or lost, there will be mostly changes are seen mostly in the intracellular fluid volume, because out of 13 parts, 9 parts are distributed to the cells. So whenever there is water depletion or water intoxication, that means excess, the changes are seen mainly in the intracellular fluid. So that will manifest with symptoms and signs. Changes in the volume of sodium containing fluid. That means any electrolyte containing fluid, if there becomes excess or deficit, it produces the disturbances in the mostly in the extracellular fluid compartment. So extracellular fluid compartment can produce changes in the intravascular volume also in the ratio of 4:1 or 3:1. Changes in the potassium leads to malfunction of cellular conduction. So these are the main gist of presentation. Now let us study about water imbalance, water depletion. So it is depletion of water without concomitant electrolyte loss. So only just plain water depletion causes insufficient intake of water due to weakness, coma, dysphagia, gastrointestinal surgery. Clinical manifestations. So that means there is no loss from the body. Plain water deficit occurs to the body whenever there is decreased water intake. So in that case, what will happen? Thirst is the main cause, main feature. Circulatory failure doesn't manifest as water depletion mainly causes intracellular dehydration. Diagnosis: elevation of serum sodium indicates a relative lack of extracellular fluid water and vice versa. So there will be sodium will be increased in serum. That means it is not true increase. It is because water is decreased, sodium appears to be elevated. That means sodium electrolytes become concentrated because water has been reduced. An elevation of 3 milliequivalents of sodium represents a deficit of approximately 1 liter of body water. What is the normal serum sodium? What is the normal serum sodium? Yes, average is 140 milliequivalents per liter. So treatment: if swallowing is possible, intake of water by mouth is increased or water is given by nasogastric tube feeding. If oral intake is contraindicated, so plain water can be given intravenously in the form of 5% dextrose. So 5% dextrose is administered intravenously as simple plain water cannot be given because it causes hemolysis of RBC. 5% dextrose is osmotically equivalent to plasma's osmotic pressure. Then water intoxication. There is excessive, it causes excessive IV administration of 5% dextrose. So if someone is not aware of the electrolyte solution, electrolyte free solution, so if some saline has to be given to the patient, so whatever that is available in the ward, if they start giving, or intentionally if they give large quantities of 5% dextrose, because some people what they want to do is when the patient is feeling weak, they give dextrose. So when the patient is feeling more weak, just like that, to give nutrition to the patient, if they give dextrose, 5% dextrose in more quantity, then that can lead to water intoxication. Then colon washout with saline-free water in children with Hirschsprung's disease. SIADH syndrome, that is syndrome of inappropriate ADH secretion, like wart cell carcinoma, lobar pneumonia, empyema, head injury. Then TURP syndrome, that means transurethral resection of prostate. So in this, we have seen the prostate is being resected. So there will be a lot of oozing from the prostate bed. So that it is frequently being washed away by injecting water through the cystoscope channels to clear the blood. So if this water is given, this water gets absorbed and that causes the water intoxication. Excess of electrolyte-free water is distributed among the intracellular and extracellular compartments. The early changes of water excess are seen in the brain because the brain cells are swollen, and the swollen brain cells cannot be accommodated in a tight calvarium and present as features of raised intracranial tension. So whenever there is water intoxication, the first clinical manifestation is as raised intracranial tension. So the features due to raised intracranial tension being drowsiness, apathy, weakness, delirium, and later convulsions and coma. And the generalized rise of intracellular water will be there. This causes profuse sweating and vomiting of clear fluid. Investigations. Sodium content of the plasma is low. Water intoxication can cause cerebral edema if serum sodium concentration is below 120 milliequivalents per liter. Low sodium in the plasma can also be due to increased solutes like untreated hyperglycemia, mannitol administration, and renal losses. If due to renal losses, the urine estimation of sodium will be more than 20 milliequivalents per liter. Now, I am explaining this particular paragraph. If, for example, a patient with delirium, coma, fits is admitted to your ward, because the patient is profusely sweating, you will suspect the water intoxication. You take serum sodium estimation. It is 120 milliequivalents. So then you will be under the impression that yes, because sodium is diluted, that means it is water intoxication. But low sodium level in the serum can also be due to excessive sodium loss. Even if there is excess sodium loss also, sodium will be low. So how to know that? Urine estimation of the sodium, urinary estimation of sodium. If it is more than 20 milliequivalents per liter, that indicates that the reduced sodium level in the serum is because of some renal problem causing high excretion of sodium in the urine. It also can be diluted because if there are increased solutes like hyperglycemia, untreated hyperglycemia. Blood sugar is more than 500 milligrams percent. So there is high sugar level in the serum. So whenever there is high sugar in the serum and extracellular fluid, what they do? They draw more water because glucose is an osmotically active substance. So it draws water. So the fluid, extracellular fluid gets increased in quantity and sodium gets diluted. PCV is also reduced because there is more dilution of the blood also. Treatment, water intake is stopped, masterly inactivity. Administration of hypertonic saline infusion. Some people try it, or mannitol to promote diuresis. Then changes in sodium. So whenever there is change in the sodium, automatically the extracellular fluid volume is altered because sodium draws water. It is the main cation of the extracellular compartment. So its changes reflect the changes in the volume, changes in the water volume. As sodium is the principal cation in extracellular fluid, the changes reflect ECF volume changes. Sodium depletion means it indicates reduced ESF volume. So the reduced ESF manifests as reduced intravascular volume in the ratio of 3:1. Causes losses of fluid from gastrointestinal tract due to vomiting, diarrhea, nasogastric aspiration, and administration of diuretics. Clinical features, they are due to extracellular dehydration, dry inelastic skin, sunken eyes, scanty high-colored urine. In infants, anterior fontanelle is depressed, tongue is coated and dry, peripheral circulatory failure if the ECF losses exceed 2 to 2.5 liters. That means if the person vomits about 2 to 2.5 liters of vomiting, for example, then he will go into peripheral circulatory failure. That means if there is 2 liters loss, that means there will be roughly about 500 to 750 ml of volume deficit will be there in intravascular volume. So we have seen whenever there is deficit of about 750 ml, there will be the overt compensated shock. So patient exhibits this overt compensated shock. So this table represents how much ECF loss will produce clinical symptoms. So between 2.5 to 3 liters, the intravascular deficit will be around 750 ml and there will be class 1 shock. 3 to 6 liters of ECF loss will lead to 750 to 1500 ml of intravascular deficit, produces class 2 shock. 6 to 8 liters of extracellular fluid loss will have 1.5 to 2 liters of intravascular deficit and manifests with class 3 shock. More than 8 liters of extracellular fluid loss will represent with class 4 shock. Of course, these are all the tennis score classification of the clinical manifestations of hypovolemic shock. Around 750 ml, 150 to 1500 ml, more than between 1500 ml and 2 liters, then more than 2 liters. So these are the things already we studied about this table. So this table tells you about the degree of shock. Investigations. The diagnosis of sodium disturbance is a clinical diagnosis made on physical examination for features of hypovolemia and CVP measurement. So sodium disturbance is measured by clinical parameters of shock and dry inelastic skin and dry tongue. It is not judged by serum sodium estimation. Serum sodium estimation will tell you about water level. Sodium hypo or hyper level is demonstrated by clinical findings. So serum sodium concentration is not a measurement for sodium balance. Hematocrit is elevated. Treatment: IV infusion of normal saline. In severe cases, administration of colloids to restore circulating blood volume. Then sodium excess. So whenever there is sodium excess, there will be raised ESAF value. Causes: over-enthusiastic IV administration of saline, hyperaldosteronism, and corticosteroid abuse. Corticosteroids also have the sodium sparing action, so they cause sodium accumulation. So clinical features of sodium excess: puffiness of the face, rails at the base of the lungs whenever there is 1500 ml of fluid excess, barely perceptible pitting edema, then edema of the dependent areas, pulmonary edema, ascites, anasarca. So these are the features of the hypersodium or sodium excess. Treatment: infusion of saline is stopped. Loop diuretics, bronchodilators, mechanical ventilation of the above measures fail. Okay. Manognya has a doubt. Investigations of sodium balance. She has a doubt. The thing is, I will explain it once again. We have seen in the water imbalance. Whenever water is decreased, there is concentration of the extracellular fluid compartment, making the sodium levels will be rising. Similarly, when water excess is there, ECF compartment is diluted, so sodium levels they decrease. So sodium levels are helpful to know about the water excess or water deficit. If there is sodium loss, so when sodium is lost, then how do you identify it? You will identify it by clinical findings, not by sodium estimation. Because whenever sodium is deficient, sodium, for example, the patient has vomited. He will not simply vomit sodium. He will vomit sodium containing fluid out. So sodium is being decreased from the body. Total body sodium has decreased. So whenever sodium goes out from the extracellular fluid compartment, water also goes out along with it. So if you take just 100 ml of blood and then check the sodium concentration will not change, but total sodium in the extracellular fluid compartment has decreased. But as the water also is decreased, you do not find a disturbance in the sodium concentration in the plasma. So to identify sodium disorders, you must mainly concentrate upon the clinical examination. In case of sodium depletion, that means there will be electrolyte fluid depletion. So that means the patients will be having dehydration features. Then you can ask me, the same dehydration is there in water depletion also. Then what was the difference between water depletion and the sodium depletion? In water depletion, the changes are mainly seen in the intracellular compartment. Because we have seen plain water means it gets distributed amongst the three compartments in the ratio of 9:3:1. When loss is there, so more loss is there from the intracellular compartment. So there is more intracellular water depletion. So patients will experience the features due to intracellular water depletion. And of course, little amount is there from ECF also, That is helpful to do sodium estimation, so that we will say whether water, the fluid compartment has become concentrated or diluted. If sodium depletion is there, for example, intracellular compartment is not affected. Extracellular compartment is affected. What is the effect? Sodium decrease means water also is decreased. So the ultimate concentration of sodium in the plasma is not altered. So you have to depend upon the clinical findings like features of hypovolemia and features of dehydration in form of sunken eyes, dry tongue, dry inelastic skin, plus features of hypovolemic shock. So these things will help you to make the diagnosis of a sodium deficit. Similarly, sodium excess. Sodium excess is clinically evident with the features of more of water in the extracellular compartment. So the patient will be developing rales, crepitations, breathlessness, edema in the dependent areas, later generalized edema, later even collection of fluid in the pleural cavities and lung in the peritoneal cavity, that is ascites. Both clinical features are not same. In plain water depletion, the patient's manifestation is only thirst. In case of sodium depletion, there will be features of hypovolemic shock. If plain water depletion is there, there will not be any shock. If plain water is excess, the patients will have drowsiness. They will go into delirium. They will get convulsions. They get coma. If the sodium is excess, then patients will develop edema, pulmonary congestion, edema of the peripheries, edema of the dependent areas, edema of the ensarca, then there will be peritoneal and pleural collections. Okay. Sodium excess. Shahja, you have a doubt in what conditions sodium will increase? Sodium is increased whenever you give over enthusiastic IV administration of saline, or whenever there is hormonal disturbance like hyperaldosteronism, corticosteroid abuse. And actually, there can be secondary hyperaldosteronism even in case of cirrhosis of the liver. That also produces hyperaldosteronism. That is why one of the causes of ascites in cirrhosis of the liver is because of hyperaldosteronism. Okay, now we'll go to potassium balance. Normal quantity in ECF is about 4.3 milliequivalents per liter. You can say 3.5 to 5.5. In the cells, it is 140 milliequivalents per liter. So large stores of potassium in the cells act as a buffer for absorbing changes in the ECF. So if the ECF potassium decreases, the potassium from the cells will accommodate it, and vice versa. Potassium levels in the ECF influence cell function, especially neuromuscular transmission. So potassium level not only in the cells, but even in the ECF, if there is change in the potassium level, that will cause disturbance in the cell function, especially neuromuscular transmission. Potassium depletion causes chronic diarrhea, gastrointestinal fistula, diuretics, shift of potassium into the cells. That means sometimes there will be decrease in the ECF potassium because potassium has shifted into the cells. So this occurs in alkalosis. So whenever there is alkalosis, that means the alkaline content of the plasma is high. To reduce that, then the acids from the cells will come out. So because the acids come out, in their place, the potassium shifts into the cell because sodium cannot go. Then there will be shift of potassium while if the insulin is being administered, because insulin pushes glucose into the cells. It promotes transport of glucose into the cells. So when glucose is being transported, automatically potassium also gets transported into the cells. So there is always some transport of potassium from the cells into the ECF and from the ECF into the cells. Then aldosterone also shifts it. Clinical features of hypokalemia. It increases membrane excitation potentials, making the nerve and muscle less excitable. There will be extreme muscle weakness, slurred speech, hypotonia of the muscles, paralytic ileus, weakness of respiratory muscles. Then there will be even weakness of the cardiac muscle and cardiac conduction system, producing cardiac arrhythmias. So hypokalemia causes arrhythmias and weakness of skeletal and smooth muscles in the body. Investigation, serum potassium estimation, and ECG changes. ECG changes, T wave changes are the earliest. So ECG changes being prolonged QT interval, depression of ST segment, lowering or inversion of T wave, and presence of U wave. So these are the ECG findings in hypokalemia. You have to by heart these ECG changes because whenever in the examination, PG entrance examination, and as a short notes, this is frequently being given. Treatment of hypokalemia, oral potassium supplements like milk, fruit juice, meat extracts, or potassium chloride solution or tablets, 2 grams 6 hourly. So if they are administered, the potassium will be corrected. IV potassium if oral intake is contraindicated. IV administration is given when the urine output is adequate and alkalosis is not present. It is given by adding 20 to 40 millicalories of potassium to 1 liter of 5% dextrose or normal saline and infuse it over a period of 6 to 8 hours. Sudden and rapid infusion causes cardiac arrest in diastole. So you should not give potassium chloride straight into the vein. You must give it only as a slow infusion mixed with saline or mixed with dextrose. So please remember this point. So once you come to the house urgency, sometimes your professor may ask you to administer potassium to one particular patient. So you must know this point. You must add this to 1 liter of 5% dextrose bottle, and you must make the drip rate so slow that the whole bottle lasts for about 6 to 8 hours. Slow administration must be given. Any rapid administration of potassium will cause disturbance in the conduction mechanism of the heart. If you take this 20 ml in a syringe and then if you just push it, before you draw the syringe out, the patient is dead because there will be cardiac arrest. Potassium excess, whereas hyperkalemia causes renal failure, shift of potassium from cells into the ECF, example acidosis, extensive tissue damage, beta blocker administration, and severe exercise. So the main cause of hyperkalemia is renal failure. For example, just now we have seen potassium is richly available in the fruits. So if you take 1 kg of mangoes in the summer, will it cause hyperkalemia or not? because you are giving more potassium to the body, of course, through oral route. If you take 1 kg of fruits, will it cause why? Will it cause hyperkalemia or not? Why? Wonderful. Kidney is very sensitive for potassium levels. If potassium is even slightly excess, kidney excretes it out. So a normally functioning kidney will not permit potassium to accumulate. That is why whenever there is hyperkalemia, you always suspect renal failure, that kidneys are not functioning. Clinical features of hyperkalemia: cardiac arrhythmias. If potassium is more than 7 millioccurrence per liter, it can cause arrhythmia, bradycardia, and cardiac arrest. Paralytic ileus, muscle weakness. So paralytic ileus and muscle weakness are same in the both. In hypokalemia and hyperkalemia, there is muscle weakness and paralytic ileus. That means smooth muscle and skeletal muscle weakness is there. Investigation: serum potassium estimation. It will be lesser than 3.5. Sorry, it will be more than 5.5. ECG changes will be there. Peak tall T waves, shortened QT interval, elevated ST segments. Almost opposite of the hypokalemia. Treatment. So the kidney is not functioning. That is why you must take the other routes for elimination. So ion exchange resin. That means there are some resins which will exchange one ion for the other ion. You give it by mouth, that goes into the gut and it absorbs potassium from the gut ECF and it excretes out. There is ion exchange resin, but it is not very effective. Then IV infusion of insulin in 5% dextrose. So you give dextrose and insulin, then what will happen? This potassium will be pumped into the cells. Most important is manage the renal failure by dialysis. IV calcium gluconate, because hypocalcemia aggravates features of hyperkalemia. Then you correct alkalosis by giving soda bicarb. So this is about potassium sodium balance and water balance. Now we'll go to the topic of the acid base balance. Okay, mixed venous oxygen saturation is nothing but arterial blood gives oxygen to the tissues. The cells extract oxygen. Then venous blood is depleted of oxygen level. So if you check the vena cava, you take the blood and then you study the oxygen saturation level. Similarly, you test the arterial blood oxygen saturation. So there will be reduction of oxygen saturation in the venous blood because oxygen is being extracted by the cells. So how much will be there? The reduction will be between 50 to 70%. So 50 to 70% of arterial oxygen saturation will be there in the main veins blood sample. Now, for example, if the oxygen saturation in the venous blood is less than 50%. What does it mean? More of oxygen is being extracted by the tissues. That means tissues are more oxygen avid. So whatever little oxygen, whatever oxygen that is coming to it, it is extracting it. So this is a feature in case of the hypovolemic shock. Because hypovolemic shock, there is vasoconstriction. That's why sufficient amount of blood is not flowing. So whatever blood that is flowing there, the tissue cells, they extract the oxygen. Otherwise, they will go into anaerobic metabolism. Already they are anaerobic metabolism because even the oxygen is not sufficient for them. So more of oxygen is extracted by the tissues in case of the hypovolemic shock and in cardiogenic shock. But in septic shock, there is improper utilization of oxygen by the tissues. Because there is vasodilatation, there is fluid exudation, and there is opening of arteriovenous shunts in the tissues. That means there is disturbed microcirculation. So because of the disturbed microcirculation, the oxygen extraction by the tissue cells becomes poor. That means there is tissue anoxia is there. So oxygen is not being utilized. So this oxygen returns to the venous blood. So when you test the venous blood, it will be more than 70% of oxygen will be there. So that indicates that the tissues are not properly utilizing oxygen. They are unable to utilize the oxygen. So there is decreased tissue perfusion. Whenever there is vasoconstriction, the blood flow is decreased, but RBC are not affected. RBC are carrying oxygen. So the amount of blood that's coming to the tissues has decreased because of vasoconstriction. But the RBC are having the sufficient amount of oxygen in them. But when the vascular flow is normal, there is to be about 100 RBC, for example. But vasoconstriction is there is only about 30 or 40 RBC are coming into the cells. So that oxygen is being extracted by the tissue cells. So the oxygen gets depleted there. So it is a slow flow through the tissues. So there is peripheral vasoconstriction. Because of that, there will be utilization of more oxygen by the tissues. Okay, is it clear? Okay, now we'll go to the acid-base balance. Normal pH of blood is between 7.36 and 7.44. Acid means one that gives hydrogen ion. Alkali means one that accepts hydrogen ion. The normal hydrogen ion concentration in the blood is 0.404 milliequivalents per liter. Such low levels are difficult to be measured and expressed as log of H ion concentration, that is pH. Whereas enzymes of the body work efficiently at that pH, and hence any alteration will alter their function. Normal body metabolic activities produce about 15,000 milliequivalents of hydrogen. So the normal body metabolic activities produce 15,000 milliequivalents of hydrogen per day, but the pH is maintained at 7.4 by acid-base regulation. The lower limit of pH at which a person dies is 6.8 and the upper limit is 8. Basic physiology, the pH is maintained by buffer systems, lungs and kidneys. So whenever there is alterations in the pH, normally the body metabolism produces more acids. That is why the pH will be falling. So there will be more addition of hydrogen ions every day into our body tissues and body fluid. But our pH is maintained constantly at 7.4 level. How? That is because of the buffer mechanisms, because of the lungs and kidneys. So all these three will be working together. Whenever the blood pH is altered, immediately the buffer systems are activated to prevent excess changes in the pH. The buffer systems are bicarbonate carbonic acid, hemoglobin, bone and tissues. So hemoglobin absorbs acids and releases acid whenever there is alkaline. So similarly, bicarbonate and carbonic acid, this is a good buffer system which neutralizes the changes in the pH levels. The most important buffer is bicarbonate and carbonic acid. The change in their ratio leads to disturbance in acid-base balance. More of carbonic acid in relation to bicarbonate causes acidosis and vice versa. So more of carbonic acid in relation to bicarbonate causes acidosis and vice versa. I hope you followed this statement. So whenever the carbonic acid and bicarbonate ratio, if you see, if carbonic acid is excess side, that is acidosis. If bicarbonate is excess side, that is alkalosis. Carbon level is altered by lungs and bicarbonate and acid levels by the kidneys. Now you see normal pH. This is carbonic acid and this is bicarbonate. The ratio is around 20:1. That is normal. So at this 20:1 ratio, the pH is 7.4. I am trying to simplify as much as I can. So if it is 20:1, the pH will be 7.4. The lungs, they exhale and inhale carbon dioxide. So when the respiratory rate is decreased or when the respirations have become shallow, the normal carbon dioxide produced in the alveoli is not being excreted. So there will be more accumulation of carbon dioxide in the blood. So there will be carbonic acid excess will be there. Similarly, the patient is doing hyperventilation. So more of carbon dioxide is expelled out. So there will be reduction in the carbonic acid level in the blood. So the carbonic acid level is influenced by the lung mechanism, either hyperventilation or underventilation. The bicarbonates are being controlled by kidneys. Whenever there are excess, they are excreted out. Similarly, whenever there are more hydrogen ions, the hydrogen ions are also excreted by the kidneys. So mainly the kidneys and the lungs, they perform the duty to buffer the or to control the acid base level with a pH of 7.4. Now, for example, the ratio got altered because there are more of hydrogen ions are being secreted. So more of hydrogen ions means already HCO3 is there. This HCO3 combines with those hydrogen ions and they form H2CO3. So now there will be H2CO3. So there is more of H2CO3 and the ratio has been altered. Instead of 20 is to 1, it has become 15 is to 1. If it is 15 is to 1, then there will be pH of 7.1 only, not 7.4. So in this situation, what will happen is the lungs automatically the respiratory center is depressed. Sorry, when carbonic acid is in excess, the lungs will exhale more carbon dioxide outside. Compensated mechanism I will tell you later. So just I am telling only about this is acidosis. Acidosis means whenever the ratio gets altered, instead of 20 is to 1, if the 20 becomes less, we call it as acidosis. This is an example of alkalosis, where the bicarbonate concentration in relation to carbonic acid has increased. So the ratio has become 25 is to 1. Then we call this as alkalosis. I hope now you got the point. So acidosis and alkalosis are reflected by the ratio between the bicarbonate and carbonic acid. Now let us see compensatory mechanism. If acidosis is there are more of hydrogen ions being added to the circulation that cause more of carbonic acid accumulation. That means the ratio has changed here. It has become 15 is to 1. So the pH has become 7.1. So whenever the pH has dropped, carbonic acid is in excess when compared to bicarbonate. Then what will happen is more of carbonic H ions will be excreted by the kidneys and the acid levels fall. So it reaches up to 20 is to 1 reaches the excretion. And the other mechanism is more of carbon dioxide is excreted. So when more of carbon dioxide is excreted means more of carbonic acid is being decreased. Carbon dioxide in the blood will be in the form of carbonic acid because dissolved in the water in the plasma. So more of carbon dioxide is exhaled out. So there will be fall in the carbonic acid level. So the compensatory mechanisms whenever there is acidosis is excretion of H ions by the kidneys. Number 2, excretion of more carbon dioxide by hyperventilation of the respiration by the lungs. These are the two mechanisms. Alkalosis. Now let us suppose the ratio is 25 is to 1. There will be shallow respiration. With shallow respiration, there will be more carbon dioxide accumulation that produces raised carbonic acid level. Kidneys excrete more of bicarbonates, and thereby the carbonates decrease and the ratio comes to the normal. Disturbance in acid base alteration in carbonic acid level are the respiratory factors. The respiratory factors indirectly influence the carbonic acid levels. So if the respiratory factors are involved in production of acid-base disturbance, this is called the respiratory acidosis and respiratory alkalosis. So the respiratory factors mainly influence the carbonic acid level. Alteration in bicarbonate levels, that means either bicarbonate increase or decrease. Anything can cause the acid-base disturbance. So alteration in the bicarbonate levels will produce metabolic acidosis, metabolic alkalosis. When the bicarbonates are excess, we call it as metabolic alkalosis. When the bicarbonates are less, we call it as metabolic acidosis. So measurement of acid-base disturbances. So how do you measure? You measure the acid-base disturbance from the arterial blood. You have three parameters here. One is pH parameter, normally 7.3 to 7.44. The other parameter is the partial pressure of carbon dioxide in the arterial blood. This is denoted as PaCO2. So PaCO2 means it represents carbonic acid. It is 31 to 42 millimeters of mercury pressure. Then third factor you see is the bicarbonate level. This is 22 to 25 milliequivalents per liter. So these three parameters, if you study, you can say what type of acid-base disturbance is there. What type of disturbance? If you look at the pH, you can say it is acidosis or alkalosis, but that is only 50%. Complete diagnosis is whether it is metabolic or respiratory factors are involved in the acid-base disturbance. I hope you are following. Of course, this is not required. Now, metabolic alkalosis. What is metabolic alkalosis? Already I told you. Metabolic means it is the bicarbonate level that tells you about metabolic activity. Causes metabolic alkalosis, that means there is excess of. What is metabolic alkalosis? What do you understand if I say metabolic alkalosis? Yes, very excess of bicarbonate is metabolic alkalosis. So the causes excessive ingestion of alkalis. Example in acid reflux disease, that is called milk alkali syndrome. In olden days, whenever a patient is having gastric region or acid belchings, immediately what they used to think is they have more of acid in the stomach. So to neutralize the acid, they used to take the soda bicarb powder. The soda bicarb powder is nothing but the baking soda that is available in the kitchen. So they used to take that baking soda and they used to swallow that. This baking soda that goes and causes the alkalosis, increased absorption of bicarbonate producing metabolic alkalosis. Then vomiting of gastric juice in pyloric obstruction or nasogastric aspiration. We have seen in the pyloric obstruction, gastric outlet obstruction with vomitings. Can you recollect what is the metabolic disturbance that is produced? I told you then there is a very frequently asked question in the theory examination. What are the biochemical changes produced due to pyloric stenosis? Okay, you are right. It is the metabolic alkalosis due to hypochloremia. That is most important. Hypochloremic alkalosis with hypokalemia. That also will be there, and hyponatremia. Very good, wonderful. And of course, there will be paradoxical aciduria in late stages, not in early stages. Paradoxical aciduria indicates a late stage. Okay, wonderful. So vomiting of gastric juice produces metabolic alkalosis. Then excessive administration of corticosteroids. So here, compensation is done to maintain carbonic acid and bicarbonate level at 1:20. By respiratory system to increase carbonic acid levels, and by kidneys to eliminate bicarbonate. Already told you. So whenever there is disturbance, the respiratory system and kidneys, they try to compensate and bring it back to the 20:1 ratio. So because of the compensation by the lungs, there will be shallow respiration. In alkalosis, there will be shallow respiration. So the patients will have slow and shallow respiration. If it is prolonged, it can lead to Cheyne-Stokes respiration. So lungs try to compensate by retaining more of carbon dioxide. There may be tetany because in alkalosis, the ionic calcium falls. So when though total calcium is normal, whenever the ionic calcium falls, it leads to the tetany. Then there will be features of associated hypokalemia because the potassium from the ECF will go into the cells in place of hydrogen ions that are coming out from the cells. Treatment, the cause should be corrected and high urine output is encouraged. If associated with hypokalemia, there may be massive loss of potassium. So replacement of potassium is done slowly under careful monitoring of levels of potassium, ECG, and urine output in an intensive care unit along with IV fluids. Then loss of bicarbonate or excess of acids other than carbonic acid. So this is called as the causes loss of bicarbonate. It occurs in diarrhea, high intestinal fistula, vomiting, or aspiration of intestinal juices. Excess of acids, it occurs in excess of ketone bodies, lactic pyruvic acid, that is in shock. Then metabolites due to renal failure. So whenever there is renal failure, the normal body metabolites, which are acids, they are not excreted out. When you look at the normal pH level, it is 7.4. And urine pH, it will be 6.6 to 6.5. That means urine pH is always acid in normal persons. Why? Because the body metabolites produce acids, and these acids being excreted by the kidneys. That is why there will be always acidic urine. So whenever renal failure is there, those acid metabolites cannot be excreted out, so they accumulate and they produces the acidosis. Hyperchloremia in transplantation of ureters into the colon. Compensation is done by lungs to excrete carbon dioxide and to reduce bicarbonate. Anion gap, already we discussed some time ago. The total of cations is equal to total of anions. So total of cations means sodium and potassium are the main cations. Then anions means chlorates and bicarbonates plus other anions. The amount of anions other than chlorates and bicarbonate is 10 to 16 milliequivalents per liter and is called the anion gap. So if you look at it here, there are chlorates and bicarbonate. Other than these two, whatever that are there, they are called as the others. So they will be around 10 to 16 milliequivalents per liter. Bicarbonate alters in any change in the chlorates or anion level to keep the total level constant. The anion gap is increased in ketoacidosis, lactic acidosis of shock, salicylates poisoning, and in renal failure causing reduced bicarbonate. That means the others will increase here. The others can be due to ketone bodies, lactate and pyruvates in shock, salicylates poisoning, and renal failure due to increased metabolites. So the others will increase. So whenever the others increase, the bicarbonate cushions for the increase. So when they increase, the bicarbonate decrease. So that's why the patients will go into acidosis. If chloride is reduced in the blood, bicarbonate increases, and vice versa. So in acidosis, the body tries to compensate acidosis by secreting or by pushing out more carbon dioxide. So more carbon dioxide is eliminated by hyperventilation. It seems Santhi didn't follow about anion gap. The total of cations is equal to total of anions. Potassium and sodium and magnesium, calcium. So the total will be put together, it will be around 145, let us suppose. The anions also will be 145. And they will be always equal. I hope now it is okay. Yes. So the total number of anions is equal to total number of cations. If there is disturbance in anions, the cations are not altered. Sodium, potassium, they are normal. But this side, the anions being chlorides, bicarbonate, and others like phosphates, sulfates, etc. So all of them put together is equal to the total number of anions. Up to that is clear. Okay. Now, if there is any alteration in this anion level, for example, chlorides, the patient is losing a lot of chlorides in the vomitus, as in pyloric obstruction. So levels is falling here. So when chloride levels fall here, then so if the chloride, it is not like this chloride has come only this much. So this is the chloride. So when the chloride has decreased, what will happen? The bicarbonate will increase to make up the total of anion level. Vice versa. Similarly, if chlorides increase, there will decrease bicarbonate. So whenever bicarbonate decreases or increases, that will produce the metabolic acidosis or alkalosis. So I will now ask you one question. If the patient is vomiting and he loses a lot of chlorides, then what will happen? The chlorides decrease. So to compensate the total, the bicarbonates will increase. So patients will get metabolic alkalosis. Very good. Similarly, if you have infused more of chloride, if you are given intravenous more chlorides, then what will happen? There will be metabolic acidosis. Similarly, if the others are there, others, for example, if the patient is having diabetic ketosis, that means ketone bodies, they are all anions. So normally the ketones are not there. Even if they are there, only they are a very small quantity. But in diabetes, untreated diabetes, sometimes there will be a condition called ketosis. So in ketosis, what will happen? There will be large amount of ketone body collection here. So whenever there is large amount of ketones are collected here, the others are increasing. So when the others increase, what should happen to the bicarbonate? The bicarbonate will decrease. So there will be acidosis. That is why in diabetic ketosis, there will be always metabolic acidosis. So this others is called the anion gap. Similarly, sulfates have increased. Then again it produces acidosis. So if others and chlorides, when they increase, the bicarbonate decrease. When they decrease, the bicarbonate increase to compensate the total value of cation level. They must be made equal to the anion level. So this is called the anion gap phenomena. So when others are increased or chloride is increased, the bicarbonate decreases, producing metabolic acidosis. When they decrease, bicarbonate increase to cause metabolic alkalosis. So whenever there is metabolic acidosis, patients will have hyperapnea to compensate by excessive respiratory stimulation where carbon dioxide is excreted more. Anion gap means the others is called anion gap. Chloride and total anions minus bicarbonate is equal to anion gap. In investigation, reduced bicarbonate, PaCO2 may also fall if compensated by lungs. Treatment, the cause is treated. Example, increasing circulating volume of blood and support of ventilation in case of hypovolemia. Indications for administration of bicarbonate solution, acidosis due to loss of bases, severe acidosis less than 7.21, then in acute acidosis due to prolonged cardiac arrest. Treatment, rapid administration of sodium bicarbonate may result in seizures due to transient CNS acidosis. So this is about metabolic acidosis and alkalosis. Now let us study about the respiratory alkalosis. Why anion gap is unaffected in alkali loss in diarrhea? Because in alkali loss in diarrhea, the bicarbonate is affected directly, not the anion. The bicarbonates are lost. That's why there will be metabolic acidosis. Okay, respiratory alkalosis means deficiency of carbonic acid, that is PaCO2. So any respiratory factor is denoted by the carbonic acid level. Over enthusiastic ventilation of an anesthesia patient, hyperventilation due to hyperpyrexia, hysteria, and high altitude. So whenever a person does overventilation or hyperventilation, there will be more excretion of carbon dioxide that causes reduction in the carbonic acid level, and that produces the respiratory alkalosis. Clinical features: fall of blood pressure during anesthesia, latent tetany. Whenever alkalosis is there, there will be tetany. Treatment: treat the cause, administer carbon dioxide insufflations. Respiratory stenosis causes inadequate ventilation of an anesthesia patient and pre-existing pulmonary disease, that is COPD. Treatment of the cause. Respiratory stenosis is always associated with hypoxia. Respiratory compensation is slow to act and mechanical respiratory support is needed. Now, I will give some examples of acid-base disturbance. Whenever you are asked to tell about the acid-base disturbance by giving the parameters value, how to make a diagnosis? First is measure the pH. Look at the pH. It is less than 7.4 acidosis, more than 7.4 alkalosis. That is simple. Next is look at the PaCO2. Already I told you PaCO2 means it indicates what factor? Metabolic or respiratory? Yes, it represents respiratory factor. That's carbonic acid factor. Okay. So if PaCO2 is more than 40 millimeters of mercury pressure, because it is 7.4, it is acidosis. So 40 millimeters of mercury pressure more, that means it is respiratory acidosis. Less than 36 is respiratory compensation. Similarly, on alkalosis side, if it is less than 36 millimeters of mercury pressure, it is respiratory alkalosis. If it is more than 40 millimeters of mercury pressure, it is respiratory compensation. Did you understand this? Then we will go to the third step. What about others? Okay. Anyway, Afsan Nizami has not followed this. I will repeat this again. Now you have a patient. You have tested for the pH level. pH level is 7.2. That means you say it is acidosis. Then you want to know whether it is metabolic acidosis or respiratory acidosis. Okay? You check the PaCO2 level. If the PaCO2 level is more than 40 millimeters of mercury pressure, so this respiratory factor is causing acidosis, because more than 40 means there is more of carbon dioxide. More of carbon dioxide means there is more of carbonic acid. So carbonic acid is responsible for acidosis. So you call it as respiratory acidosis. I hope this is clear. If the partial pressure tension is less than 36, if it is less than 36 millimeters of mercury pressure, normally 36 to 40. So in acidosis, carbon dioxide level is low. Why? Why means because when it is less than 36 means it is not the cause for the acidosis. Is it okay? If it is less than 36 means it is not the cause for acidosis. Okay. Then why it is less than 36? Because patient is having acidosis. It wants to excrete out more of acid outside. How can it excrete acid? By exhaling more of carbon dioxide. So carbon dioxide is being exhaled out and that has produced reduction in the carbon dioxide level. That is why the carbon dioxide tension has fallen. So what does it mean? That means the respiratory tract is doing the compensatory mechanism to reduce acidosis. So you can say it is compensated the metabolic acidosis. Similar thing here also. Now, so you test for PaCO2, then you test for bicarbonate. If bicarbonate is level less than 25, it is metabolic acidosis. If bicarbonate is more than 25, it is metabolic compensation. Similar on the similar lines. Then if it is more than 25 on the alkalosis side, it is metabolic alkalosis. If it is less than 25 means it is metabolic compensation. It's very good. So whenever their compensating mechanisms are there, the acidosis and alkalosis will be corrected. But in spite of their compensation, if they are not corrected, then only you will get the pH disturbance. Every day, every minute, we are getting disturbance in our body acid-base balance. But the pH is being maintained. Why? Because of the compensations taking place in the buffer systems, in the respiratory tract, and in the kidneys. They are doing the function 24 hours. That is why our pH is maintained. If by any chance we lose more of something, either bicarbonate or gain more of bicarbonate, or we inhale or exhale more rapidly or more slowly, that can cause the disturbance. So in spite of compensation, the pH will be either increase or decrease. So even that increase or decrease is only marginal, 7.3, 7.2, 7.4, 7.5, 7.45, 7.46, like that. If 7.4 becomes 6.5, that means the patient is not there. So much disturbance will not be there because the body's compensations are there already. So if the compensation is not working, is not sufficient to work, then there will be disturbance in the pH. If you have followed, answer my question. This is the example of a patient in the ICU. This is the ABG sample. That means arterial blood gas analysis report. pH is 7.2. Its PaCO2 is 60 millimeters of mercury pressure. Bicarbonate level is 26 milliequivalents per liter. Now you tell me the diagnosis. Okay, because the bicarbonate is 26, there is 1 milliequivalent more. You are telling metabolic compensation. There is a very slight change. You can ignore it. Or you can say metabolic compensation, no problem. But there is a very slight change. That is why you can ignore it. So it is a case of uncompensated respiratory acidosis. Because the change in the bicarbonate is only 1 milliequivalent. So there can be, because normal variation will be there. So it is a respiratory acidosis. Then tell me answer for this. pH 7.3, PaCO2 60 millimeters of mercury pressure, bicarbonate 35 millimoles per liter. Yes, very good. It is compensated respiratory acidosis. Wonderful. This one, pH 7.31, PaCO2 40 millimeters of mercury pressure, bicarbonate 20 millimoles per liter. Yes, it is metabolic acidosis uncompensated. Very good. Now look at this and then tell me the answer. You are saying metabolic ABC, you are telling metabolic compensation. Why do you say it is compensation? It is a alkalosis. What the bicarbonate is doing here? Bicarbonate is reduced. That means it is okay. Respiratory alkalosis, metabolic compensation. Yes, you are right. Manognya, why you say uncompensated? Manognya, why you say uncompensated? Okay, slight decrease. Okay, but it is almost about some 2 to 3 milliequivalents decrease is there. So you can say just compensation. This is a compensated respiratory alkalosis. Okay, Afshan, you have a doubt. Why can't it be metabolic alkalosis? If it is metabolic, okay, let us say it is metabolic alkalosis. Then what will happen to the bicarbonate level? If it is metabolic alkalosis, will it be more or less? Option, if it is metabolic alkalosis, it should be more. But what you are seeing here, is it more or less? What is it you are seeing here? It is less. So then how can you say it is metabolic alkalosis? It can't be metabolic alkalosis. So it is only a compensation. Actually, it is reduced. Not too much, but it is reduced. So you can say it is a compensated respiratory alkalosis. Then answer this one. Sayanthi and Manognya, why do you say it is compensated? Respiratory acidosis with compensation, you said. Where do you find the compensation? Bicarbonates, are they trying to reduce acidosis? pH 7.2. So are they trying to reduce acidosis? No, they are not reducing. But what they are doing instead? They are also falling. So then bicarbonate is 18 only. 18 means what is it? Is it acidosis or alkalosis? So acidosis. So now what is the condition? Tell me the total condition now. Respiratory factors showing acidosis, metabolic factor showing acidosis. Both are showing acidosis. That means it is a combined respiratory and metabolic acidosis. So the patient is having both the problems, metabolic problems as well as respiratory problems. So this usually occurs in a patient with shock having pre-existing pulmonary disease. So whenever he is having pulmonary disease and he goes into shock, they will go into respiratory acidosis as well as metabolic acidosis. So there will be no compensatory mechanism available for them. So that is a very severe problem because there is nothing to save them, help them in the body. So they go into acidosis very fast and they do not come back from acidosis so soon. So it is a combined respiratory and metabolic acidosis is very dangerous. They need very high dependency care in ICU. So this is seen in cardiac arrest. As that can be seen in COPD patient as well as it can be there in cardiac arrest also. So you have to give sodium bicarbonate to correct the, because there is no compensator mechanism here. You have to, from external side, you have to give. Already we have seen when pH is less than 7.2, you have to give sodium bicarbonate. So you give sodium bicarbonate formula, 0.3 into weight of the patient in kg into base deficit. Normal is 25, so here base deficit is 7. 7 is the base deficit, weight of the patient, then multiply by 0.3. So you get total amount in milliequivalents. 1 milliequivalent of sodium bicarbonate is available in 1 ml of 8.4% solution. So you give that 8.4% solution. So this is about the electrolytes and acid base. Now let's apply this to a surgical patient. So how you administer fluids and electrolytes? So a guide to fluid therapy and electrolyte therapy. So once you become a house surgeon, the chief will tell you, yes, give IV fluids to this patient. That's all. What IV fluids he may tell or he may not tell. Even if he doesn't tell, you must calculate what IV fluids are required for the patient and you must write down there. and you must give those IV fluids. So the fluid therapy in a surgical patient. Indications for fluid and electrolyte replacement: to replenish loss of fluids and electrolytes like vomiting, diarrhea, sepsemia, etc. As maintenance therapy in patients who are not taking food and water by mouth. Example, post-operative patients where there is nil by mouth instruction, and patients with severe dysphagia, anorexia, and who are comatose or who are on ventilator. So they need daily maintenance requirement. Then to prevent shock in severe burns patient with predictive fluid loss. Estimation of fluid and electrolyte replacement in a surgical patient. So the amount of fluid and electrolytes required by surgical patient depends upon the following: present deficit, probable deficit, that means expected ongoing losses. That means the patient has came to you, for example, with vomiting. So at the time of admission, you estimate how much fluid the patient has lost, and that much of fluid and electrolytes has to be replaced. That is present deficit. After admitting in the ward, the vomitings may not stop abruptly. He may have 2, 3 more or more vomitings. So for each vomiting, how much he is going to lose? So that is the expected or ongoing loss. So depending upon the amount of that losses that happen, you have to replace. That is ongoing losses. Then daily maintenance requirement must be provided. So whatever the daily maintenance is there, that has to be given to the patient. So first of all, estimation of existing defects. How do you come to the conclusion how much the patient has lost? By history. Inquire from the patient or attendants regarding the following: history of limited intake, how long he is having, presence of thirst, quantity and nature of losses. What he is losing: diarrhea stools or vomiting. Vomiting means bilious vomiting or plain gastric acid vomiting. If it is gastric acid vomiting, the losses will be sodium, potassium, and chloride and hydrogen ion. If it is bilious, means the patient will be losing a lot of electrolytes as well as alkaline. Then clinical examination, because any sodium loss will produce the hypovolemia. The hypovolemia can be classified by tennis score classification. Then general condition examination: sunken eyes, dry tongue, pale, anxious face, inelastic skin. These are all the signs of dehydration. Presence of pulmonary or peripheral edema. Urine output, because in oliguria there will be decreased urine output. Normal expectation is 60 ml per hour. So that is how you come to a conclusion whether the patient is having the present deficit, how much he is having. The ongoing deficit, you will see from time to time whatever he is losing, and that loss must be replaced. In addition to these present deficit and ongoing losses, you have to add also the maintenance fluid must be given every day. The maintenance fluid is every day a person requires about 2 liters of plain water. That is 5% dextrose can be given along with some sodium and potassium. So that is the maintenance liquid. So once your fluid is being given, you must continuously monitor whether whatever the fluid you are giving is sufficient to the patient. Is it causing undernourishment or it's causing overhydration? So the parameters to be observed are respiratory rate, oxygen saturation, temperature, systolic blood pressure, pulse rate, level of consciousness, fluid input output charts. That means whatever fluid you give to the patient, you must record on the input side. Whatever the patient gets output, the output may be in the form of urine, in the form of Rayleigh tube aspiration, in form of fistulous discharge, in form of diarrhea stools. So whatever the patient passes out, you record it. That is the output. So fluid input output charts. They are very, very helpful to chart out whatever fluid what you are giving is adequate or not. So volume replacement is done as per losses. The type of output is noted to replace the lost electrolytes. So you look at the type of output. If it is simple gastric juice, because it contains hydrogen, chloride, sodium, potassium, so its loss produces volume depletion and chloride responsive metabolic alkalosis. So we have seen produce hypochloremic alkalosis. So gastric juice loss must be replaced by normal saline, which contains sodium and potassium. Weight of the patient to be recorded frequently. That will tell how much gain in weight is equivalent to gain in water. The laboratory investigation, serum biochemistry, sodium, potassium. Sodium, it indicates ratio of electrolytes to water in the extracellular fluid and is a poor indicator of whole body sodium status. Already we have seen the sodium is evaluated by clinical findings rather than by biochemical findings. Hyponatremia is most commonly caused by water excess. If change in water balance over 24 hours is known, then change in serum sodium concentration can guide sodium balance. Potassium. Hypokalemia indicates the need for potassium supplementation, and hyperkalemia indicates renal insufficiency and warrants renal function studies. Bicarbonates and chlorides, blood gas analysis and estimation of PaCO2, PaO2, and HCO3 helps to identify the acid-base disturbance. Urine biochemistry, urine sodium concentration. I think you are all following because this is all what we have just now discussed. So these are the monitoring things what you have to do. Urine sodium concentration reflects renal perfusion and a low value indicates renal hypoperfusion. ECG, it helps to identify potassium abnormalities. Then how do you estimate the ongoing losses? The fluid and electrolyte losses will continue even after the initiation of fluid therapy in certain conditions, like post-operative gastrointestinal surgeries in form of nasogastric aspiration, fistula drainages, ostomy discharges, etc. These estimated fluids are administered over the next 24 hours, and the quantity and quality of fluid is changed depending upon the vital parameters, amount of ongoing losses, and laboratory findings. So depending upon the losses and the other parameters like pulse rate, blood pressure, the skin turgor, tongue dryness, you have to modify the fluid input. Daily maintenance, the daily requirement of water and essential electrolytes are as follows. 20 to 30 ml per kg per day of water. That is approximately 1 milliequivalent of per kg per day of sodium, potassium, and chloride, and approximately 50 to 100 grams per day of glucose to limit starvation ketosis. So these are the things that are required. So this comes to approximately for a 75 kg individual 2 liters of water with 70 milliequivalents of the sodium, 70 milliequivalents of potassium, and 70 milliequivalents of chloride with 50 to 100 grams of glucose per day. So these are the things that are required as daily maintenance. So if the fellow is not taking anything by mouth, these things must be substituted. Method of fluid and electrolyte replacement in the surgical patient. So this is how you calculate the quantity of fluid required for a patient who is in need of fluid therapy. So whenever a patient is brought to you for fluid therapy, you must estimate the amount of fluid that is required. How do you estimate? What are the existing deficit? So the deficit is evaluated by tennis score classification, electrolyte estimation. You get a approximate amount of fluid that is required to infuse, and the patient will be losing still under your treatment. So the ongoing losses has to be replaced. The third thing you have to remember is the maintenance therapy. The maintenance therapy means you must give 2 liters of 5% dextrose with added sodium, potassium, and chloride, 1 milliequivalent per kg body weight in 24 hours. So that much has to be given to the patient. So this is the fluid therapy in summary. Then how do you give this fluid to the patient? You can give by oral route or by intravenous route. Oral rehydration therapy indications in the conditions of water and electrolyte deficit where the deficit is less than 1.5 liters and oral intake is feasible or not contraindicated, then you can give oral therapy. If the deficit is more than 2 liters, then oral therapy will not be adequate to infuse. For example, a patient comes to you with diarrhea. So you check the blood pressure, you check the pulse rate, skin turgor. So by that you can calculate how much fluid the patient has lost. If it is less than 1.5 liters, you can give him oral rehydration therapy with ORT, oral electrolyte solutions. If it is more than 1.5 liters, then you must admit him and then you must give him intravenous fluids. Method of oral rehydration therapy, feeding the water and electrolyte mixture depending upon the nature and quantity of losses. Nasogastric feeding tube and feed the patient. If the stomach is having some disease, you can pass the tube directly into the jejunum and you can pass through the jejunal tube. Disadvantages, monitoring of accurate absorption is not possible and hence in acute fluid losses it is not ideal method. It is not possible to administer in obstructive disorders of gastrointestinal tract. Advantages, problem of fluid overload is not present, stimulates gastrointestinal motility, epithelial integrity and secretions. So one route of fluid therapy is by oral therapy. So when it is less than 1500 ml, if there is no lesion in the gastrointestinal tract, you can give by oral therapy. Oral therapy can be given by just by drinking or by passing them through a tube. The tube can be put into the stomach or into the jejunum. Then IV fluid therapy. It is a method of choice for acute management of fluid deficit. Method of IV fluid therapy. Principle is to maintain adequate cardiac output. This is achieved by assessment, resuscitation, routine maintenance, replacement, redistribution, and reassessment. Assessment, the fluid deficit is assessed by history, clinical methods, and laboratory investigations. Resuscitation, when the patient is in acute fluid deficit, ABCD of resuscitation is followed. That means first you look for the airway, then breathing, then circulatory assistance. So circulatory assistance means you give the IV fluids because this is a fluid deficit case, acute fluid deficit. So IV fluids are given to replace the lost fluids. Resuscitation, a bolus of, so how do you give IV fluids? First you give a bolus of 500 ml of Ringer's lactate is given and the response of the patient, systolic blood pressure, pulse rate, urine output, oxygen saturation, CB monitoring is monitored at the end of 15 minutes. Or you can raise the lower limbs by 45 degrees. After 30 to 90 seconds, the hemodynamic improvement is seen, means it indicates that volume replacement is required. So these are the simple tests to know whether the patient requires volume replacement or not. If the condition of the patient deteriorates by developing breathlessness, it indicates that the patient was fluid overloaded. If the response is favorable, the fluid administration is given depending upon the estimated fluid deficit and monitoring. Whenever you give IV fluid therapy, you should be careful in renal impairment, cirrhosis, sepsis, or cardiac failure. So in these patients, there can be fluid overload and can cause the deleterious effects. So daily maintenance, you can give it 1.5 to 2 liters of 5% dextrose added with 50 milligrams of potassium and 0.5 liters of normal saline. So this will be the daily maintenance requirement. Replacement, the ongoing losses are anticipated and replaced volume for volume and type for type. It is monitored regularly and adjustments are made. Redistribution, patients with marked internal fluid distribution changes or abnormal fluid handling, such as those with sepsemia, post major surgery, those with cardiac, liver, or renal comorbidity develop edema from sodium and water excess and some sequestrate fluids in the GI tract or thoracic or peritoneal cavities. These patients should be handled in an intensive care unit. That means when you are giving this IV fluid therapy for a patient with cardiac, liver, or renal diseases, so the patient's response will be totally different because they get overhydrated very soon, but the parameters are not corrected. That is why they need special intensive care management wherein you administer CVP or PAWP and then you monitor the organ perfusion and then you manage. So this is not for an undergraduate, but you should know that patients with cardiac, liver or renal morbidity, they should be handled in intensive care units. Regularly, you must monitor whether the patient is getting overhydrated or underhydrated by these factors. You look for the body weight, systolic blood pressure, pulse rate, pulse pressure, skin turgidity, mucous membranes, lungs, jugular veins, urine output. So volume depletion means body weight is low, blood pressure is low, pulse rate is raised, pulse pressure is low, skin is dry, inelastic, mucous membranes are dry, lungs dry, jugular veins not visible, the urine output is scanty. In case of overload, body weight gain will be there, systolic blood pressure high, pulse rate normal or low, pulse pressure high, there will be pitting edema, mucous membranes are moist, rales at the base of the lungs, jugular veins are engorged, there will be diaphysis. So by this, you will say whether the patient is having overhydration or underhydration, and you will adjust the fluid therapy. So one method of giving fluids is by oral route. The second method of giving fluids is by IV route. The third method of giving fluids is by rectal route. This is called rectal administration. In remote places where intravenous fluid administration is not available and clinical intervention is indicated, a rectal fluid infusion is useful. It is administered by passing a tube, that is Foley's catheter, into the rectum up to 10 centimeters and 0.9% sodium chloride in water with potassium at rates of 100 to 400 ml per hour is given slowly because the colon can absorb water and electrolytes. So you take this principle to have the fluid therapy. The hemodynamic improvement is seen after 2 or 3 hours of treatment, with the patient retaining up to 500 ml of saline solution per hour. It is a safe, effective, and low-cost technique in emergency situation without the facility for IV fluid administration. So in very remote villages or remote places where medical facilities are not available, where IV drip is not available, then immediately you can put the normal tap water with salt and potassium and you can administer, but glucose should not be given. Only electrolytes can be given like this. It is not a substitute for intravenous fluid therapy. Once effective intravenous access has been established or available, rectal fluid infusion should be discontinued in place of IV fluid administration. Then the fourth method is subcutaneous fluid administration. It is suitable for mildly to moderately dehydrated adult patients, especially the elderly. Approximately 3 liters can be given in a 24-hour period at 2 separate sites. So these things are all only for theory purpose. You should give only oral route or intravenous route only. The subcutaneous method was very old technique, so it is not being employed. because you have no control over the fluid administration. So just I will skip it. This is only so this is about the fluid therapy. Of course, it may be boring to you. Unless you are in house urgency, you cannot follow it properly. But for the time being, what you should know is the basic principles of fluid therapy being you have to replace the losses. The continued losses must be replaced. Daily maintenance therapy can have to be given. You can give by oral routes, intravenous routes. The other routes which also can be employed but not in common usage are rectal route, subcutaneous route. So now we'll go to the surgical nutrition. Will you read this or shall I tell? Nutrition support. We have two more topics. One is surgical nutrition or nutrition in surgical patient. The other is metabolic response to trauma. The nutrition is a general topic. You can just read in your book. So if you can read, I will go to the topic of metabolic response to trauma. Of course, the nutrition you know, but the thing you have to there are some questions on the methods of nutritional support. So I will tell you them. How you support a surgical patient for nutrition. Enteral nutrition, parenteral nutrition. Parenteral nutrition is frequently given in the theory examination as a essay question or sometimes short notes question. Enteral nutrition. In all cases where nutrition support is indicated, enteral nutrition is the first choice to be employed, and parenteral nutrition is advised when the enteral nutrition is not possible, contraindicated, or not tolerated by the patient. Enteral nutrition contraindications: intractable vomitings and diarrhea, paralytic ileus, intestinal obstruction, distal high output intestinal fistula, peritonitis, severe shock, severe GI hemorrhage, short bowel syndrome. So in these conditions, enteral nutrition is not advocated. The enteral formula: calories are provided by simple sugars and long chain fatty acids. Proteins are provided in the form of the amino acids or peptides. They are fortified with vitamins, minerals, and trace elements. Newer formula has glutamine and fiber to maintain nutrition and integrity of the intestinal epithelium. Methods of enteral nutrition: oral feeding, either normal food intake or like sip feeding. That means you advocate the patient the nutrient food to the patient, or you can advocate sip feeding with oral supplements, or you can do tube feeding. That means you can put a tube into the stomach or jejunum and can feed him. Patient is encouraged to take diet with the nutrient formula with proper diet advice to provide necessary calories, proteins, minerals, vitamins, and trace elements. Complications: vomiting and diarrhea. Patient may not accept the formula. Sip feeding. It is indicated in patients with normal food intake but with compromised appetite, where the appetite is not there. So you have to advise him to have sips of food. So 200 calories of energy with 2 grams of nitrogen or 200 ml per 200 ml are provided in each feed. It is given in the form of multiple sips of feed at frequent periods. Tube feeding: nasogastric tube into the stomach or nasoduodenal intubation, or by gastrostomy, that means a tube passes directly into the stomach in some disorders of the esophagus, or into the jejunum. If you are giving tube feeding, depending upon the type of undernutrition, the state of the gastrointestinal tract, the following types of enteral formula are used: hypertonic or isotonic formula, immune enhancing formula, calorie dense formula, high protein formula, elemental formula. So this all depends upon the patient's requirement depending upon his disease. Method of administration: infusion as a bolus or a continuous infusion. Complication of tube feeding. For these are the complications. So advantage of enteral nutrition: maintain intestinal integrity and mucosal function, maintain peristalsis, prevents bacterial translocation, cheap and easy to administer. Safe compared to parental nutrition. Total parental nutrition. Yes, I want to tell about this one because this is frequently given in the examination. Definition: it is administration of all nutrients by intravenous route without the use of gastrointestinal tract. Parenteral. Parenteral, other than enteral route. That is the meaning. Indications: when energy requirements cannot be met or cannot be provided by enteral nutrition. Example: massive resection of the bowel, high intestinal fistulae, chronic intestinal failure. Routes of parenteral nutrition. So parenteral nutrition can be given through a peripheral vein. The necessary nutrients are provided by intravenous administration into a peripheral vein. Central vein access. Nutrients are given through a catheter placed in the superior vena cava, possibly like intrajugular or subclavian veins. Principle of giving: intravenous infusion of nutrients in elemental form. Patient must be hemodynamically stable. Peripheral parenteral nutrition. Short-term feeding. Only for 2 weeks feeding you can give for peripheral veins. Why? Because for parenteral nutrition means the total daily requirement of nutrition has to be given through intravenous route. When you give such high concentrated things to the intravenous route, there will be thrombophlebitis and the veins will close within a day. That is why what the surgeons will choose is they choose the central veins and directly they infuse into the internal jugular vein. So into the internal jugular vein there will be large amount of blood will be flowing, about 2 liters of blood per minute. So in this 2 liters of blood, if you give small about 5 ml or 10 ml of fluid per minute, that gets dissipated without producing much osmotic disturbances. That is why the central veins are being preferred. So the formulations being isotonic fat emulsions and glucose with amino acids. Disadvantages of peripheral parenteral nutrition is thrombophlebitis. That is why you go for central vein parenteral nutrition method. The veins used for cannulation are external jugular, internal jugular, subclavian veins. Guided insertion and ultrasonic guidance is preferable. The cannula is passed into superior vena cava and tip is placed at the distal end of the superior vena cava. Formulations 50 to 70% dextrose. So you see high concentration. Normally you give only 5% dextrose, but in parenteral nutrition you give 50 to 70% dextrose. That means it's hyperosmolar. The hyperosmolar will produce thrombophlebitis and they produce crenation of the RBC. To prevent that, what you do? You administrate into central veins. Central veins will have large flow of blood. So in that large flow of blood, if you add little amount of this 50 to 70% dextrose, it doesn't cause much alteration. Then 10 to 20% of amino acids, 10 to 30% of lipid emulsions are given in various combinations along with electrolytes, minerals, and vitamins. Complications of total parenteral nutrition: technical problems, sepsis secondary to contamination of the central venous catheter, pneumo or hydrothorax, cardiac arrhythmias, cardiac tamponade, air embolism, thoracic duct injury, hydromediastinum, blockage of the tube. So all these complications are mainly because of the technical problem. That means during insertion of the tube, sometimes the tube may penetrate and pass into the pleural cavity or into the mediastinum or into thoracic duct, and these problems will ensue then. Metabolic complications, refeeding syndrome in malnourished individuals and patients on now if you give nutrients through the veins, they will go into the blood. Through the blood, they will go to the tissues. They are giving amino acids, the glucose, and fatty acids. That means they are all pre-digested, so they doesn't require any digestment with the intestinal tract. So they are the elemental things. So once they are given, they go directly to the tissues. They even just like absorb from the gut. So from the no, once we give into the veins, they will go into the right atrium. From the right atrium, they go into the right ventricle. From the right ventricle, they go into the pulmonary circulation. From the pulmonary circulation, they go into the left ventricle. From the left ventricle, they are pumped by the aorta. Through the aorta, they will go into the various parts of the body. What is refeeding syndrome? In malnourished individuals and patients on prolonged fasting, when total parenteral nutrition is administered, fluid and electrolyte shift occurs, resulting in hypophosphatemia, hypocalcemia, hypomagnesemia, which can result in altered myocardial function, deteriorating respiratory and hepatic function, tetany, central nervous system abnormalities like confusion, convulsion, coma, and death. Prevention, monitoring of electrolytes daily and supplementing the needed and avoiding overfeeding. Then miscellaneous complications, hyperosmolar dehydration, hepatic steatosis, increased fluid retention, hyperglycemia, insulin resistance, chronic fatty acid deficiency, electrolyte abnormality, hypertriglyceridemia, hypersensitive reactions, hypercalcemia, hyperaminoacidemia, uremia, overfeeding syndrome, cholestasis and gallstones, intestinal mucosal atrophy. Because intestines are not being used for long, parenteral nutrition is being advocated, so patients get intestinal mucosal atrophy. So this is about the parenteral nutrition. If total parenteral nutritions are equiosmolar, just I will tell you one thing. What is daily requirement of calories? 2000 calories. 1 gram of glucose yields 4 calories, 4 kilocalories. So to give 2000 calories, that means 2000 calories is daily requirement. So how much glucose you have to give? 500 grams of glucose you have to give. So 500 grams of glucose you have to give intravenously. So that should be dissolved in water. So in how much water you can dissolve? Daily requirement of water is only 2 liters or 2.5 liters. So if you mix 500 grams in 2 liters, how much percentage is there? 500 grams in 100 ml is, 500 grams in 1 liter is 50%. 500 grams in 2 liters is 25%. That means you have to give 25% solution. So 25% solution means it cannot be isoosmolar. You can give only hyperosmolar. The hyperosmolar solutions cannot be given through peripheral vein. If you give through the peripheral vein, they get thrombus. That is why you have to give through central veins. So total parenteral nutritions are not isoosmolar. That means equiosmolar. They are always hyperosmolar. when compared to plasma. Okay, just within you, if you can bear for another 10 minutes, I will complete the metabolic response to trauma. Otherwise, if you have some puja and all that, because today is Shravan Shukrovaram, I will skip this for the next class. So shall I continue or shall I? Okay. Okay, we are going to talk about metabolic response to trauma. So why we have to know about the metabolic response to trauma? Because you are doing surgeries on the patient and you are giving fluids to the patient. So for example, during surgery, the patient has lost some fluid due to evaporation. He has lost about 1.5 liters. So in the post-operative period, will you give this 1.5 liters or not? So estimated loss is 1.5 liters. So immediately after operation, will you give this 1.5 liters or not? If you give this 1.5 liters, it will be excess. Why? That is because of metabolic response. What is metabolic response? So let us study about effects of injury on fluid balance. Now in the nature, the animals move around. For example, a deer is there. So the lion sees the deer and then it attacks it. So ultimately, the deer got injured. So its fellow members cannot help it to feed. That means it has to take rest. It cannot move. It cannot fetch water. It cannot fetch foods. Then how can it survive? So the metabolic response is to make the person survive when trauma occurs. How? The aim of metabolic response is to conserve body fluids to provide energy resources after trauma. So because the patient's ability to move, to get water will be decreased. So in that circumstances, the body as a protective mechanism develops this metabolic response, whereby it conserves body fluids, provide energy resources from the body after trauma, and it enhances wound healing. So there are three phases: phase of alarm reaction, phase of catabolism, phase of anabolism. Phase of alarm reaction. So one is injury, fight or flight response. Immediately after injury, there will be tachycardia with increased muscular contraction, with increased breakdown of intrinsic glucose to yield more calories. This is by reason of so immediately after injury, there will be rise in the BP, tachycardia with increased muscular activity, breakdown of intrinsic glycogen releasing calories. For example, there is a fight in the nature if two fellows are fighting. So when two fellows are fighting, there may be a response of fight or there may be a response of flight. It is whether it is fight or flight response, The body should be geared to do intense activity all of a sudden. That is why there will be a rise in the cardiac output, there will be tachycardia, there will be increased muscular activity, and the glycogen in the muscles, they break down to give glucose for immediate supply of glucose to the tissues. That means the tissues are now geared for immediate, rapid, and swift action. So either fight or flight requires this. So immediately after trauma, even if you make a patient to lie down on your table, give him anesthesia and take a stroke on the skin, you will find these changes. If it is completely sedated under anesthesia, these changes will not be seen. Otherwise, these changes will be seen. We are doing this, for example, local anesthesia. The patients will get there is some network problem here. The problem. Now, are able to see the slides? Are you able to see the slides? Okay. Okay. This is called the phase of alarm reaction. This is mediated by release of adrenaline hormone. Then phase of metabolism. This varies with severity of the trauma. It may be 1 day after the herniorrhaphy, 4 to 5 days after gastrectomy, 10 to 15 days or more after burns. So after herniorrhaphy, for 1 day, the patient will be in phase of catabolism. After gastrectomy, he will be for 4 to 5 days in phase of catabolism. The changes which occur are, there will be sodium and water retention due to ACTH and ADH secretion. Potassium excretion is augmented, but due to increased release of potassium from the injured cells, hypokalemia does not manifest during this phase. So due to surgical stress, there will be secretion of ACTH and ADH. Under the influence of ACTH and ADH, there will be water retention and there will be sodium retention. Sodium is retained, potassium is excreted. So there will be excretion of the potassium, but also there will be more addition of potassium from the injured cells. So the injured cells, they give more of potassium. That is why the potassium levels are not usually altered. But there will be sodium retention with water retention. So immediately after injury or after surgery, there will be sodium and water retention. There will be negative nitrogen balance due to catabolism of proteins. So because of this corticosteroid hormones and adrenaline hormones, there will be neoglucogenesis where there will be negative nitrogen metabolism where the proteins are broken down. Proteins means the muscle proteins are broken down to yield energy. This phase is exacerbated in sepsemia, pain, starvation, immobilization, and this phase is attenuated by minimal access surgery, blockade of afferent pain by epidural anesthesia or efficient analgesic drugs, and early mobilization. and adjusting periods of starvation. So this is the phase of catabolism. Then phase of anabolism, there is nitrogen conservation, there is hypokalemia due to passage of potassium along with nitrogen into the cells. There is normal sodium and water metabolism. So this is the metabolic response to trauma. So basing upon this one, you have to calculate intraoperative fluid therapy. So if fluid deficit is present, it should be corrected before surgery. During surgery, the requirement depends upon the amount of losses. So blood loss during surgery, fluid evaporation during surgery. So these two should be tackled during surgery. Then post-operative fluid therapy, immediate post-operative period, due to metabolic response to trauma, the requirement of water and sodium is less. The total requirement is given with less of sodium and less of water. So if 1500 ml of water is required, you give less of 200 or 300 ml. And sodium also should be restricted in the immediate post-operative period. The fluids are given evaluating the patient frequently by vital data and central venous pressure monitoring. Potassium is not administered in the early post-operative period because there will be addition of potassium from the damaged or traumatized cells. Summary: the day of operation, existing loss, expected loss, maintenance fluid of 1.5 liters is given, not 2 liters, you give only 1.5 liters. Monitoring of vital data every 15 or 30 minutes is essential. First post-operative day, input-output charts are seen. If the output exceeds input, it indicates deficit. Urine output of 2 liters with normal vital parameters indicate adequate balance. Of course, this is not required for you. To later post-operative period, daily maintenance of potassium 40 to 60 millicrons per day is given. Potassium is replaced for GIT losses at the rate of 20 millicrons per each liter of GIT aspirate. So the metabolic response to trauma is mainly 3 phases. The immediate period, that is the alarm reaction. Next is phase of catabolism. This phase of catabolism is dependent upon severity of injury. In minor injury, it will be there, it may not be there. In a moderate injury, it will be there for 1 to 2 days. In severe injury, it can be there for anything up to 15 days or more. During this phase, there is sodium retention and water retention, and there is potassium loss, and there will be nitrogen loss. Nitrogen loss means the amino acids or proteins in the muscles, they are being converted to glucose. That is phase of catabolism. After the phase of catabolism, there will be phase of anabolism, where there is nitrogen conservation, there is potassium is pushed into the cells. So the patients will go into hypokalemia, where patients should be supplemented with potassium and nitrogen supplementation. So that is the essence you have to know of the metabolic response to trauma. Any doubts? Okay, if you have no doubts, I will close this session. And next session, what do you want? Next topic, what topic you want? If you want to read, just I will close this session, or if you want any topics, I will take those topics. Okay, burns, very good. Salivary gland swellings, S. Soft tissue lesions, skin and soft tissue, okay. So as continuation of this shock chapter, in the next class, I will tell you the burns and some other topic for the next week. So I will see that the next week will be adjusted with these topics. salivary glands, skin and soft tissues, and the burns. So any of these things I will accommodate there. Okay. We will have the class from Monday. And Santi, about this oxygen saturation in the peripheral vein, the central vein. You don't go with this. You once again go and read Bailey and Lowe. And about this 50%, if still it is there, you just ask me in the next class, I will tell you. But for the time being, what you remember is what I have said. That means in this hypovolemic shock and in cardiogenic shock, there will be more extraction of oxygen. So there will be less than 50%. In case of septic shock and other distributive shocks, there will not be much oxygen utilization by the tissues. So there will be more than 70% oxygen available. So you remember that. So with this mind, you please check the Bailey and Lowe once again. And if you have any problem or doubt, I will clear it again. Okay, see you again on Monday at the same time. Thank you.